So welcome everybody to our Radical Geography seminar series. We thank you for joining us, and we thank a lot Manjari Mahajan, Professor Manjari Mahajan, who is joining us from New York. Manjari is professor and co-director of India-China Institute at the New School. Her work lies at the intersection between science and technology studies, development studies, and anthropology. Research and teaching at the New School includes a topic of global health, philanthrocapitalism, and digital governance. As we agree, today she will speak about COVID-19 and the shifting contours of global health in an unequal world. We thank her a lot, and Manjari, the floor is yours.
Should I explain some technical stuff first, Kostis, just rapidly? Θα πάρουμε ερωτήσεις στα αγγλικά κατά προτίμηση, ή μπορείτε να πάρετε το λόγο αφού μιλήσει η Manjari, ή μπορείτε να γράψετε τις ερωτήσεις σας όσο μιλάει, ή κατευθείαν στο chat, ή όσες και όσοι παρακολουθείτε στο Facebook. So we can take questions in English. Αν είναι στα ελληνικά θα τις μεταφράσουμε εμείς, μην διστάσετε. Πάντως, ευχαριστούμε. Manjari, the floor is yours now.
Thank you very much, Iris. And thank you, Kostis, for this wonderful invitation. I'm honored to be presenting to the seminar. This is a very new group for me. I should admit at the outset that my disciplinary background is not in geography, but hopefully that will make the discussion more rather than less interesting. Maybe I'll try and share my screen now. Can you see it?
Yes.
Great. Okay. So let me get started. The title is slightly different than the one that Kostis read out. So before COVID vaccines were rolled out a few months ago, one of the most stark facts of the first year of this pandemic was that wealthy Western countries like the US and the UK had failed to control the pandemic, while East Asian countries, more or less all of them, had. So this was true on most measures, but perhaps it was most startling when one looks at cumulative confirmed COVID-19 related deaths, right? So as this graph shows, that the UK and the US top the list with more than 1,000 deaths per million. The UK and the US are followed by several countries in the EU. Even India, which has been in the news these days for all the wrong reasons, once you calibrate the deaths per million, it still actually comes far below the toll that the UK and the US have had. In contrast, East Asian countries have had deaths per million in single digits, sometimes double digits at most. This has been true for rich countries like Japan and South Korea and Taiwan, but also for poorer countries like Vietnam, Cambodia, and Thailand. So in this dramatic difference in how countries have managed the pandemic outbreak was not predicted. In fact, quite the contrary. The Global Health Security Index, which is a leading index that sought to measure the ability of countries to deal with large infectious disease threats, notoriously ranked the United States as the most prepared in its 2019 and 2020 report. In its 2019 assessment of 195 countries, the UK came in second after the US, while countries like Japan, New Zealand, Australia, etc. trailed far behind. And these rankings of preparedness have turned out to be clearly contrary to what the experience of the COVID-19 pandemic in the first 12 months revealed. So in my talk today, I do not want to offer an explanation for why countries responded and performed the way they did. Rather, what I really want to do is use the differential performances by the countries to put a spotlight on the field of global health. Sorry, trying to change the slide. So I want to use the COVID-19 pandemic to make explicit the frameworks that this field of global health has privileged, the narratives it has constructed, the problems it has focused on, and the interventions it has proposed. By the same token, I'm interested in making visible what was remaindered and neglected in this field. So in other words, what I'm really interested in is a kind of politics of knowledge production, a kind of politics of expertise and intervention that underlie this field of global health. When Kostis offered this invitation to me, he expressed that there was a specific interest in questions of inequality. And this is an interest that I very much share, and it underwrites much of my research, and including this presentation. But the question of inequality is not raised at the level of why are there so few vaccines available in sub-Saharan African countries? Why are patented drugs not available in the South? But rather, the question of inequality is really central to my work in how conceptualizing frameworks of global health already have in them certain kinds of asymmetries inscribed. There are already presumptions about where expertise is concentrated, which parts of the world are home to expert knowledge versus, let's say, political volatility, poor public health institutional capacity, and most importantly, presumptions about which parts of the world are reservoirs of pathogens. So maybe before I continue, I should just say that, in this, I'm interested in this politics of knowledge production in the field of global health. And I should just say what I mean by the field of global health. So here I'm referring to a regime of transnational health governance that by many scholars who study global health is understood to start sometime in the mid-1980s. So its kind of advent is really bookmarked by the AIDS pandemic. It's a field that's marked by particular actors such as the WHO, but also philanthropic actors like the Gates Foundation, public-private partnerships like Gavi and the Global Fund, and transnational NGOs and private sector actors. It's marked by particular targets which exceed infectious diseases. So there is really an emphasis on emerging diseases, emerging infectious diseases, which I'll talk mainly about today, but also chronic non-communicable diseases. This field has privileged particular kinds of tools, which have included a primacy given to metrics, to pharmaceutical technologies, increasingly to big data and evidence-based practices, and also things like there has been an incorporation of human rights tools. So it's really a field that's marked as an area of expert knowledge, policies and interventions and instruments. And I think it might be helpful to note here that in a periodization that is quite common among historians and anthropologists, global health here, the field of global health, is contrasted with, and it's understood as coming after a post-war regime of international health. So global health is understood as being distinct from international health, which is understood as kind of running from the 40s to the 80s, kind of the first 4 decades of the post-war years. So within this field of global health, just to kind of underline again, I want to focus particularly on the paradigm of global health security. Right? This schema, this paradigm of global health security has really been focused on pandemic preparedness. And it informs instruments such as the Global Health Security Index that I talked about originally in the first few minutes. So what I want to argue is that this dominant schema of global health security has identified the problem of pandemic preparedness rather narrowly, as it has identified it as emerging acute infectious diseases that can travel across borders, mainly from poor countries in the south to the north. The solutions it focuses on are narrow technical and administrative measures that are understood to effectively prevent contagion, especially in its initial stages. What this paradigm of global health security has underemphasized or sometimes completely ignored are the complex political, social, and ecological determinants that anchor a country's public health response and that are critical in ensuring a sustained well-being of the population. So for instance, I want to argue that this dominant global health security framework puts a real high premium on surveillance laboratories or stockpiles of antibiotics. In contrast, things like an equitable or accessible health system or a well-functioning state administration are given less weight. And COVID-19, however, has starkly revealed the importance of political institutions. It's revealed the importance of societal solidarity, a kind of Rousseauian general will in determining a country's pandemic response. The experience of the current pandemic, alongside older lessons from the history of international health, therefore demand a reconceptualization of this framework of global health security so that it explicitly theorizes, it explicitly takes into account the role of broader social and political drivers underlying public health. So just to briefly outline how I'll go about making this argument, first, I just want to briefly describe, just through very broad brush strokes, this paradigm of global health security, some of its history and genealogy, and its major underlying presumptions. And then I want to spend a good chunk of time focusing on a particular instrument, the Global Health Security Index, that exemplifies this paradigm of global health security. And I find it useful to focus on this technical instrument because it really serves as a lens through which to understand the underlying logics of this paradigm. And there are 3 points that I want to make about what we can learn by studying this technical instrument, about the underlying logic. So first, that animated by comparative metrics and rankings, this index carries with it a kind of foreknowledge, a kind of anticipatory knowledge, which is animated by categories, models, and presumptions that create an a priori understanding of what constitutes global health security. So it's constructed around prior categories and common templates, but as a result, such an instrument has a limited ability to incorporate surprises, learn from fast-changing events, and capture relationships that tend to be iterative and involve social learning. The second point is that by privileging assessment of those phenomena that can be easily measured in a quantitative or a yes-no fashion, this instrument helps produce an architecture of global health governance that focuses on narrowly conceived technical understandings of health. And third, instruments like this help constitute the very phenomenon that they aim to assess. So in other words, not only does the Global Health Security Index measure pandemic preparedness, it encourages countries to build the very infrastructure that it seeks to measure. So maybe I'll go on to a broad overview of the global health security paradigm. So the global health security paradigm has really provided a kind of prevailing model for how to think about pandemic preparedness. It has emerged over the last 3 decades, coming to the fore initially during the HIV/AIDS pandemic and further evolving in response to outbreaks of Zika, SARS, Ebola. In his seminal account, the book titled Unprepared, Andrew Lakoff discusses the genealogies of this global health security schema, and he discusses how it really emerges from a convergence of health, and security imaginaries. And so he kind of traces two strands which are useful to track. One is from the world of international health, and the second is from the world of US biodefense and how they get overlaid over each other. So first, there's the concept of emerging diseases that arises in the field of international health in the late 1980s during the AIDS pandemic, which is a pandemic which really upends assumptions that infectious diseases have been successfully conquered by modern public health measures. The AIDS pandemic seems to be a harbinger for a future in which ecological disruption, urbanization, rapid global travel meant that there would be a continuous emergence and spread of new diseases. So that's the international health strand. Second, in the late 1990s, US biodefense officials become increasingly worried about the threat of a bioterrorist attack. And they argue that it's necessary to draw on techniques of preparedness from the world of security to address these new threats. And so these are techniques like simulation exercises, stockpiles of antibiotics, sentinel devices, and so on. And what happens in the story that Lakoff tells is that in the wake of the SARS epidemic, these two strands converge, where the rationality and techniques of preparedness are brought to bear on the problem of emerging diseases. And this paradigm and this convergence is really installed in the World Health Organization through the revision of the international health regulations. So the policy centerpiece, the international policy centerpiece of the global health security paradigm is these international health regulations. They are first adopted by the WHO in 1969, but then they get more recently revised in 2005. And these regulations have increasingly become very central to the mandate and the responsibilities of the WHO. So what do these regulations say? The IHR, the International Health Regulations, they narrowly frame particular types of health problems of emerging infectious diseases as the relevant global security threats to focus on, right? And so the kinds of things that the IHR provides are things like decision tools to identify and categorize what are called public health emergencies of international concerns. The IHR provides common guidelines and benchmarks for national governments to detect and respond to outbreaks. The IHR requires countries to include measures such as developing disease surveillance and reporting tools, laboratory capacities for handling biological samples, stockpiles for vaccines and antibiotics and other medical countermeasures, communication systems, sufficient hospital capacity. So, I mean, this is a kind of a rapid fire run through of the kind of broad outlines of the security, global health security paradigm, but it's useful perhaps to just pause a little bit and underline what it really prioritizes. So it has these conspicuous, the global health security framework has conspicuous characteristics. One is this fear of new infectious diseases. And if any of you have been following the debates and the kind of level of interest around the origins of COVID, whether it's from a zoonotic spillover or from a lab, that really reflects this kind of interest in where new infectious diseases comes from. Similarly, IHR requirements, for instance, there have been overwhelming emphasis on developing infrastructure readiness at the national level to contain new diseases, rather than, let's say, existing public health concerns. So just to kind of, again, emphasize this, health security here is not about addressing ongoing diseases and other health-related problems in a population. Rather, these issues of routine public health security on the one hand, and new infectious outbreaks on the other hand, are considered two somewhat separate matters. And it's only the problem of new infectious diseases that is of great interest to the international community concerned with global health security. Second, there is special anxiety about contagion of emerging diseases from poorer countries, purportedly politically volatile countries in Asia, Africa, and Latin America, to industrialized wealthy nations in North America and Europe. And I mean, this is inscribed in the regulations, in the infrastructure that it asks for, in the kinds of tools that it leads to, but it's also inscribed very much, let's say, in Hollywood movies. So the IHR, for instance, emphasizes the importance of building surveillance capacities in poor countries, but the driving goal of this infrastructure in poor countries is actually to defend populations in the north. What goes alongside this kind of focus on protecting the north from the south is really the importance that is placed on reporting infectious outbreaks that emerge in poor countries to international authorities and a global machinery that includes institutes like the Centers for Disease Control in the United States. And this reporting aspect is something I'm going to come back to also. The third thing worth emphasizing is that this schema of global health security emphasizes governance through certain kinds of generic templates, generic protocols, and universal checklists that are common across countries. So there are comparative metrics and rankings that come with anticipatory categories, models, presumptions, and they are considered to be the same across countries. And so it produces what I've called a kind of foreknowledge, where based on this foreknowledge, it seeks to measure the schema, seeks to measure a particular set of features that are deemed relevant to pandemic preparedness, constructed around these prior categories and common templates. Such instruments are actually quite inhospitable to surprises. And then the final thing worth mentioning is the pandemic preparedness schema has emphasized interventions which are narrowly technical, such as building labs, stockpiles of antibiotics, and so on, right? And it's worth noting that these priorities of the global health security paradigm are distinct from an older orientation of international health that the WHO had espoused in earlier decades. So that older paradigm of international health had focused more on traditional public health measures that included primary healthcare, prevention programs, disease-specific vertical programs. That older orientation in international health worked to improve health services for the national populations. In contrast, the global health security schema is not focused on building national capacities to address existing diseases. Rather, it is targeted at new outbreaks that may or may not erupt in a population. And it's focused on how to prevent them from traveling across borders. But now I want to spend a few minutes talking about the Global Health Security Index, which is a kind of universalized instrument to measure pandemic preparedness. The GSS index vividly represents the priorities of this global health security paradigm. The authors of the index described it as the first, quote, first comprehensive assessment and benchmarking of health security and related capabilities, end quote. So it's basically a bunch of metrics which have been produced through models to report on countries' preparedness capacities. And it's useful to just kind of open that black box up of this index to see what are they seeking to measure, how are they seeking to measure it, and what do they leave out in the process. So this GS index was developed in the aftermath of the 2014 Ebola outbreak in West Africa. The WHO had come under intense criticism for not declaring the outbreak as a global health emergency early enough. And there were several calls that countries had to become more prepared to combat future infectious diseases that travel across borders. And so it's in response to such calls that the GSS index was developed and it aimed to generate more information about public health infrastructure vulnerabilities in countries around the world. This index was undertaken by the Johns Hopkins Center for Health Security at the Johns Hopkins University and the Nuclear Threat Initiative, which is a think tank based in Washington, D.C. The project was funded by philanthropic donors by and large, including the Gates Foundation and the Open Philanthropy Project. So how does this index work? It has 6 categories of indicators, which are, as the slide shows, and I'll go through them in some detail. And within these 6 categories, basically the index authors ask a number of questions, 140 questions to be precise. And the resultant data that they receive from asking these questions are used to animate 34 indicators and many more sub-indicators. Most of these indicators are explicitly quantitative, and they are informed by questions that can be answered with specific data points. So questions such as how many epidemiologists are there in this country? But there are also a number of what are called qualitative indicators, and these are based on questions that cannot be answered simply by a number, but they're typically framed in a way so that they're answered in a yes/no fashion. So an example would be, has this government passed a biosafety policy in accordance with the International Health Revolution, right? So even though it's not a numerical answer, the yes/no nature of the question allows for easy scoring. And so then these models take all the data collected for these sub-indicators and indicators, and they aggregate it, and they're rolled into one final number, which becomes the rank that is assigned to a country on a preparedness scale. And it's that ranking which tells you how prepared a particular country is. So let me just talk about some of the kind of themes that animate this index and that are reflected in the choice of indicators. The first, which I've already mentioned, which is a theme of the global health security paradigm, and it comes through this defining hallmark of the global health security paradigm is directly reflected in the number of and the choice of indicators that this index has around this kind of anxiety about contagion. So the first 3 categories of prevention, detection, and response are really all about addressing this anxiety about contagion. So roughly half of the score of any country is accounted for by these first 3 categories. And so examples of indicators would be whether a country provides annual reports of zoonotic diseases, whether a country assesses, how does the country assess for biosafety training using a particular standardized approach. There are similar questions about laboratory systems, real-time surveillance, response planning, risk communications, travel restrictions, and so on. So the emphasis is really on assessing whether a country has built capacities of surveillance and containment that can, contain an emerging infectious disease within its borders. But clearly building this kind of a surveillance high-tech infrastructure involves choices, and it involves trade-offs, which are necessarily context-driven, which each country in the best position to determine its own priorities. So you can imagine for some countries, building a surveillance system for zoonotic diseases may not be a priority if there is no history of zoonotic transmissions. Similarly, building a whole of government biosafety and biosecurity infrastructure may not be the best way to use limited funds. Instead, focusing on a primary health infrastructure might be a more urgent priority. Similarly, especially from the point of view of a developing country, it might not be effective to just add discrete technical capacities of certain kinds of pathology laboratories that feed into a global machinery for surveillance, but that are not integrated into a broader scientific infrastructure and human resources of a country. And so a country might actually prefer to build infrastructure that is tailored to its national system of research and innovation that reflects domestic needs rather than global needs. But the GHS index has little room for taking into account what might be reasonable variations between individual country priorities. And instead, there is a kind of one-size-fits-all template, a uniform template that characterizes this index, but really a large number of global health instruments that privilege quantitative comparisons between countries. The second thing that I want to talk about is this kind of emphasis that this index really has on reporting and why it has an emphasis on reporting. So individual governments are given the responsibility of not only surveillance and containment of infectious diseases, but crucially of communicating and reporting to a larger international community. So this enormous significance is prominently illustrated through the sheer number. About 1/3 of the indicators of this index have something to do with communicating or reporting to an international infrastructure. At one level, this overwhelming emphasis on reporting reflects the global health security paradigm's concern with the need to alert an international system about a possible emerging disease. The preponderant emphasis on reporting additionally echoes what have been broader trends within global health, where donors have demanded incessant audits and reports from national governments and NGOs. This reporting of national governments to global institutions and audiences has really become a kind of bedrock of an understanding of accountability and transparency. So a government's accountability and transparency here are not defined to their own people or are not defined in terms of achieving a particular health outcome, but really are defined in terms of their capabilities to assure neighbors that they can stop an outbreak from becoming an international catastrophe. So the concept of transparency that the GHS index puts at the center is really one of a kind of performative transparency or a performative visibility. And the other dynamic that this produces is that the preponderance of these indicators produce incentives to governments to invest in reporting measures, for that's what will get them better scores. And it becomes an instance yet again of how the index contributes to producing the very phenomenon that it seeks to measure. The GHS index also has a category on health systems, and this is perhaps self-explanatory because robust health systems have long been recognized as central to any country's public health capacity. But what is interesting here of how health systems are assessed is that there is a kind of checklist approach where there are quantified composite indicators such as number of doctors or medical countermeasure stockpiles, or there is an indicator about communications with healthcare workers and how that can be conducted. So you have to kind of go through this tick marking of checklists, of a checklist of quantified indicators to determine whether a health system is robust or not robust, and whether therefore a country is adequately prepared or not prepared. But what we know and what we have vividly learned through the pandemic time and again is that health systems are also inherently relational, and they have a complex relationship to the context that they operate in. Their effectivity is dependent on a range of different types of factors. And some of these are clearly matters that relate to institutional capacity, which can be captured through indicators such as number of doctors and epidemiologists. But what also affects a health system's effectiveness are considerations that relate to people's values, to a community's historical experiences with medical and public health officials, the frameworks of knowledge systems that they are working in. And this has really come home time and again with the vaccine hesitancy debates in several countries and definitely in the United States. So for instance, if communities do not trust a public health system, simply having many doctors and tests and vaccines will not be sufficient in ensuring that a population will avail of those resources. The GHS index, however, does not and indeed cannot apprehend these varied factors that are central to the workings of a health system. And this produces a systemic weakness in its ability to assess preparedness. The index also has a category which is devoted to the overall risk environment. So this category includes indicators that aim to capture broader issues. So not just discrete technical capacities like numbers of doctors, but really broader issues of political, social, economic, infrastructural, and environmental risks. So here you actually have an example, an attempt on the part of the index to capture broader contextual aspects of the society. But again, once you kind of start unpacking these indicators, it exposes how their choice is inevitably guided by this prior worldview that informs the global health security paradigm. And maybe, just for the purposes of time, I'll just look at one subcategory of risk that they work with, which is for political risk. The index has 6 indicators that aim to capture political risk that are considered relevant for pandemic preparedness. These indicators consider terrorism, armed conflict, orderly transfer of power, social unrest, government territorial control, and international tensions. So really, this is a worldview that these are indicators that are very often used to assess political unrest in what are called fragile states. So there is an implicit worldview of politically volatile countries in the South that are typically the source of emerging infectious diseases and which are plagued by problems such as terrorism and armed conflict and so on. And here they reflect a prevailing understanding that what is relevant when talking about political risks are those concerns associated with national level security, such as transfer of power, terrorism, etc. This presumed relationship between national level security and devastating epidemics was most forcefully articulated during the AIDS pandemic, when commentators, mainly based in the West, proclaimed that the HIV/AIDS pandemic threatened the national security of several African nations. These commentators frequently warned of specters of widespread unrest, coups, anarchy, and civil war. However, over the years, empirical studies that examined the actual impacts of the AIDS pandemic showed that these more alarmist relationships assumed to exist between national level state security and the AIDS pandemic were actually not borne out. The most relevant relationships between public health crises like the AIDS pandemic and governments lay not in these dramatic fears of macro level state security that had become a kind of common sense in the global health security world. Rather, the most important relationships were found to be in intermediary levels of interaction within local governments, state operations that affected health delivery, community resilience, and so on. So the AIDS pandemic actually taught us that indicators on state fragility, such as for terrorism and civil war, were wholly inappropriate in capturing what were the relevant political factors affecting public health outcomes. Despite these lessons from the HIV/AIDS pandemic, the Global Health Security Index persists with this overall approach of a paradigm that defines relevant political risks through a handful of indicators that deal with overt security threats. And in fact, what typically happens in these in the GHS index is that the indicators on political risk draw on other indexes, such as for state fragility, and it kind of produces this kind of self-referential loop of meaning and affirmation. So what is not captured in this preparedness index and what we now know is important based on the first several months of the COVID pandemic? So the COVID pandemic has taught us now, time and again, that broader historical, ecological, social factors are central to pandemic management. These are also the ones that are difficult to capture in a templatized, quantified approach of tools such as the index. So maybe the first important point to note is that countries that have provided relatively sustained and competent responses to the pandemic in the first 12 months have not followed any single path. In each country, there has been an assemblage of different institutions, policies, and social and economic factors that have enabled successful public health action. It hasn't been, notwithstanding popular media portrayals, that there has been like a single dominant factor, such as a digital surveillance infrastructure or an authoritarian regime type or technological magic bullets that have been responsible for success. Different countries have wielded different combinations of policy and infrastructural measures. They have relied on a range of local innovations, and they have operated within starkly different historical and political contexts. These countries have belonged to a range of income levels. They have different regime types. They've adopted varying border control policies. They have distinct approaches to lockdowns, testing, contact tracing, and quarantines. So preparedness has proven to come in very different packages in different parts of the world. And the diverse experiences of these countries over the last year belie the convenient notion that it is possible to make neat comparisons of preparedness using common metrics. And understanding the reasons for different countries' success, therefore, demands analytical frameworks that can accommodate nuance and divergent explanations rather than this approach of tick marking through a common checklist or modeling countries on a generic template to determine a single preparedness score. A second consistent point that has emerged from the last 12 months is that countries that have been somewhat successful have, almost without exception, they have significant state capacity. And this state capacity has taken on different forms. It's been the ability to coordinate across different ministries, sectors. It has been in the ability to act on short notice and with speed, to roll out effective communications to populations, to coordinate with both public and private sector players. Crucially, state capacity has been reflected in direct public health measures, but also in a whole host of issues that go beyond a direct public health remit. Third, what we have learned is that related to state capacity, what has been common across most countries that have had a successful response to COVID-19 is that they've had broad-based, accessible public health systems. And this was especially true in the first 12 months before vaccines became such a big part of the solution. So COVID-19 has revealed that many countries that do a good job of routine healthcare across the population are likely to be in a stronger position for emergency time pandemic care too. So it creates this imperative, a conceptual imperative, that global health security not be conceptualized as exclusively being about just combating emerging infectious diseases. Rather, it should be integrated with broader matters of health systems too. There have been other aspects that have gotten a lot of attention as being crucial in dealing with this pandemic successfully. So one topic that gets a lot of attention is the topic of trust. Indeed, trust has become a kind of catch-all phrase that encompasses a wide range of issues to speak to histories of solidarity, polarization, marginalization, and so on and so forth. People have talked about trust between scientific experts and the government, between people and the government, between medical experts and the people. And things like trust, resilience, solidarity are famously hard to identify, define, let alone quantify. There have been lots of attempts to quantify trust into discrete indicators, but these concepts clearly involve considerations that are ill-suited to quantification too. After all, it includes interpersonal and institutional interactions, how people evaluate past experiences. They necessarily implicate broader cosmologies through which people organize their lives, their values and knowledge systems, complex histories of political and scientific institutions in a country. So let me try and conclude, since I'm pretty much out of time. So the initial failures of the United States, United Kingdom, and several other countries in effectively addressing COVID-19 in the first 12 months of the pandemic have led many to proclaim that we need to be more prepared for future pandemics. And here, pandemic preparedness again is construed as following a prescribed set of technical interventions, such as building pathology laboratories, building better countermeasure stockpiles, more ventilators, more ICU units, more emergency communication systems. In contrast, I've tried to argue here that what we need to really be doing is rethinking the global health security framework and how it defines the problem and therefore the solution of pandemic preparedness. It requires a move away from narrow technical measures and towards a more explicit analysis of the role of broader social and political forces and also ecological forces that I know I haven't really talked about today. I've tried to show that existing preparedness instruments, such as the Global Health Security Index, have produced a particular kind of global knowledge about preparedness. And this global knowledge is shaped by what chosen indicators can capture. And in the process, it has rendered invisible a whole host of issues that indicators do not and cannot perhaps account for. So this knowledge that's generated comes principally through generic features that are presumed to be common across countries, including aspects that are unique to states and don't fit into a universalized framework. The one-size-fits-all template approach has become central to many aspects of global health governance, so not just global health security. Instruments such as the Global Health Security Index, they promote a style of governance that leans on checklists, cross-country comparisons, and a kind of performative visibility that is demanded of governments by global institutions. These relentless comparisons between countries produce snapshots and visualizations of the whole world in single frames, and it helps to pause and ask, for whom are these comparisons, these cross-country comparisons, truly important? Such an approach of this kind of relentless comparing countries in quantified ways is doubtlessly useful to global managerial authorities and donors such as the World Bank, the Gates Foundation, the WHO. It's also useful to academics and journalists, all of whom seek to make comparative assessments between countries. But it's notably less useful to communities and governments as they try to grapple with the pandemic on the ground. The experience with COVID-19 should perhaps force a reckoning of the limited usefulness of instruments such as the Global Health Security Index. COVID-19 has starkly revealed how the dominant global health security paradigm and its attendant instruments profoundly under-theorize and underprivilege the social political determinants of public health. It should underline the importance of analytical approaches that take seriously how health, well-being, and preparedness are determined not only by narrow technical interventions, but by broader historical social trajectories of different nations and people. Thank you.
Thank you very much, Manjari. Thanks very much. This was very fascinating, even for us. Αν υπάρχουν ερωτήσεις, if you have any questions, Κωστή, μπορείς να αναλάβεις. Ψάχνω για ερωτήσεις ή στο Facebook ή στο chat, γιατί έχω πάρα πολλές.
Do you have a lot of questions in chat?
No, we don't. That's why I'm asking people. I have a lot of questions, but I'm waiting for the chat first.
I have as well, but if anyone else from the audience,
not yet, Kosti. I think we can start. We have nobody yet from the audience. It will come as we know, as usual. Would you like to start?
Okay. Well, thanks a lot. We learned really a lot, as we expected. And I would like to really underline your initial point that although those past few weeks, the focus has been on India in terms of the deaths and etc. If you see the figure of deaths per million people, really India, it's very low compared to so-called developed countries as the UK, United States, France, and Germany. A minor point could be that although you said in the beginning that you are not working in the geographical field, I found your talk well adapted, well installed into geographical thinking. Probably you are not appreciate or you don't understand how geographically was the content of your talk, but I would like to push that a bit and go to the preparedness paradigm that you describe. For me, it was a very clear indication that this whole paradigm is really built, is really conceptualized to defend the global north. It's really a kind of, at least from my point of view, it's really a kind of changing the whole discussion and put it in a narrow technical framework. I mean, with all those protocols, all the focus on the new infection diseases while ignoring the past. And you said something at the end that this paradigm is really different or totally different, if I understood you well, with the older orientation about, let's say, building national capacity. And I would like really for you to develop a bit further what was this older orientation in terms of national capacity building. Okay, that's my first general question. I have few others, but I don't like to speak only myself. I will let others to ask questions. So please.
Thank you, Kostas. You know, I would actually love to learn from all of you as to what you see as the points of convergence between this kind of maybe more traditional SDS analysis that looks at technical instruments and processes with a kind of geographical thinking, because that's a literature that I don't very often intersect with. But I will address your question about this older paradigm of international health as opposed to global health. But I also want to just remark on, you know, this comment that you made about how pandemic preparedness as a paradigm has been developed to defend the North. And I think that's absolutely right. But it's also going to be a conceptualization that's going to be challenged, not only for the reasons that I have noted, including the terrible performance of the North in providing basic health services to its people during the early months of the pandemic, but also because these categories of the North and South are increasingly difficult to sustain when you're dealing with countries like China, which is also, the point of origin for this and maybe some other infections. But is China any longer the South? Isn't it also heavily invested in protecting itself? And so on. So, and this North-South binary around which this conceptualization has taken place is going to be very difficult to sustain for a variety of different features. But going to your specific question about contrasting what is called the current regime of the field of global health with an older regime of a field of international health. This is not a kind of original point of mine. This is a point that has been taken up by many anthropologists and historians, or within this kind of broad field of, let's say, critical studies of global health, where there is first a periodization that is broadly agreed upon, as I had noted in one of my initial slides, where international health is associated with kind of the initial decades immediately after World War II. And it's associated with large vertical infectious disease programs where national health system capacities are built on the ground. And technical agencies like the WHO or donor agencies like the World Bank really invest in building these large national health system capacities to deal with, let's say, tuberculosis or malaria or polio or smallpox. The current regime of global health, which is seen as starting roughly in the early 90s, mid 80s with the AIDS pandemic, is associated not with completely marginalizing the state, but definitely displacing the centrality of the state, both as an actor and as an analytical unit, where major global health actors like the Gates Foundation, which is the elephant in the room in global health, are very, or have at least in the initial years, but still to this date, reluctant to make governments the primary entity that they work with, right? So they have a much more plural approach of thinking about who are the big movers and shakers, who are the relevant actors. So for them, pharmaceutical companies, the financial sector, NGOs are all equally important players, right? And what they're interested in is in combating the disease rather than necessarily combating the disease in a national population. So there is a kind of analytical shift that has taken place in this era of global health with a plurality of actors and analytical units that are considered the most relevant.
Thanks a lot. I mean, I had this idea while I was asking the question, because from our field, we see a similar kind of shift away from, let's say, the more welfare kind of orientation in terms of urban regional development, in terms of discussing spatial inequalities and socio-spatial injustices, to more so-called pluralistic understanding, which, let's say, at the same time, doesn't take into account and doesn't have any interest to solve either inequalities or injustices that are resulting from the continuation of the operation of the system. So I found quite an interesting link now with the older conceptualization of global health and the current one. And before I leave my question, that has neoliberalism anything to do with this?
Yeah, it has everything to do with everything in what we talk about. It's the kind of curtain in front of which we do all our various dances. And I think maybe I don't use that term specifically because it's so difficult to give specificity to sometimes, but it's definitely in the back and front stage of this story of global health. And what you described as, you know, some of the spatial inequities in urban settings, etc., and what the problem is defined to be and how that kind of sidelines the traditional role for the state is definitely true, especially with some actors of global health, like the Gates Foundation again, you know, because I study the foundation, it will come up again and again, with lots of caveats and qualifications, because even an organization like the Gates Foundation has had to learn that you cannot work in a country like India and expect to make any sort of significant change in the national health landscape without working very closely with the government. So the foundation, when it first comes in, wants nothing to do with the government. Very quickly, it is forced to change its tune to realize that it will be absolutely, its work will be a drop in a big ocean unless it starts working with the government. So it becomes less a story of sidelining of the government as much as training the government in its own vision of what change should look like. There was another, and then I think, so even in the kind of pre-COVID time, it's a slightly more complex story of government, no government. It's a more nuanced story. But definitely, I think with the first 12 months, and I think in the coming months of COVID too, what you really see is that the absolute central importance of the state, right? Both in defining successes and in defining failures, you know, at every level. So I think this idea of the state being marginal, I think is going to be really eschewed. And I think the state is going to be back in front and center for all sorts of analysis and interventions.
Have we got any other questions before I ask mine? Έχουμε ερωτήσεις καθόλου είτε στο Facebook είτε στο chat. Πριν ρωτήσω και εγώ. So let me continue a bit on Kosti's question and just to specify a bit. Then we were saying that what you said has several geographical dimensions. And one thing that you insist upon, and I think it's very interesting, is you insist on the geographical specificity of health systems. The fact that you have a kind of a globally unifying system of accountants, which is this global health index, right? And on the other hand, you have particular paths, development paths, particular cultures, political, social contrasts. These are always geographical. So they could be national, but they could also be subnational. It's also possible, especially, I mean, in large countries such as India, we have very, you know, regional cultures too. And this is a very geographical approach. So probably without doing it consciously, this is one thing. The second level where this was very geographical was when you were talking about these interconnections between places, of all these places, nations, regions around the world to interact in this kind of a global space, right? And these things are always interrelated. So I heard it very much the same way as Kostis did, as a very geographical discussion of these issues. What I'm interested in or several issues, but I'll just ask one and see if there are any questions afterwards. You started talking about how the global health index and, let's say, global health policy at the moment very much insists on new diseases, right? And instead of existing ones. And what I'm curious, and there are other things that went on after that, you had several points there, right? There must be some kind of underlying logic behind it, right? So it's not just what you see on the surface, but the fact that they're moving from, let's say, existing diseases from which the world suffers at the moment just to new diseases must have some kind of a background that is probably not explicit, that is never said, but there must be some kind of underlying logic. And I wonder if you could tell us what is this underlying logic of this global health index as opposed to the old international indexes. Is it what you said at the end, which is for whom are these comparisons important? So is it just made to assist the Gates Foundation? Or is it some kind of an new, I don't know, what do you call them, neo-colonial logic behind this whole thing? So that's, I'm not sure if I explained my question properly.
Thank you both for specifying the geographical reasoning implicit in the paper. So that's very helpful to know because, yes, you're absolutely right. There is a kind of mapping that goes on that has a geographical specificity. And while studying global health, that kind of spatial mapping of networks and systems becomes absolutely central, especially because that kind of emphasis on a certain kind of global regime very often comes at the cost of more local, but also historical narratives that are more rooted in particular places. Your question about underlying logics that seem to drive this emphasis on new emerging diseases. I think there are many different ways to understand it. The genealogy that I think has been most thoroughly traced of this biosecurity, this global health security framework is one that I mentioned in the early part of the talk, which really is a genealogy that sees how there is a certain concern within the United States biosecurity regime. It's a kind of post-Cold War concern that arises about reservoirs of smallpox and anthrax, lab reservoirs in the former Soviet Union. So there's that strand which is developing, where there's this anxiety about how bioterrorism becomes a very important security threat for the United States biosecurity establishment to address. So that's one strand. And then there is a simultaneous strand, which is about an anxiety of emerging diseases, which starts with AIDS, but then it's about SARS and MERS and Zika, etc., which underlines for certain northern countries the idea that they haven't, as it were, won the war against infectious diseases, because even though their domestic populations might not have lots of prevalent infectious diseases, these diseases can now travel, right? And so that's the other strand, which is developing at roughly the same time. And what you see in the international health regulations and the global health security paradigm that I described is really a convergence of both those anxieties, of the US biosecurity concern and what it brings to bear on this emerging disease concern that can travel across boundaries from these febrile places in tropical countries to a more prosperous global north, where where you can bring to bear certain preparedness security measures into international health. And that's how kind of the IHR take the form that they do and produce the kinds of instruments like the Global Health Security Index that they do. So I wonder if that answered the question.
It did, absolutely. I have something in Greek that I will translate. You talked about technical interventions and the insistence on technical interventions. What is the alternative? So what are the other types of interventions that would not be of technical type?
No, that's a good question. At the outset, I want to say that it is not saying that we should not have technical interventions as part of the package, but in addition to technical interventions, especially narrowly construed technical interventions, such as, let's say, stockpiles of vaccines or stockpiles of antibiotics or surveillance laboratories, COVID-19, but also far longer histories of international health have laid out the importance of things like social policy. So the importance of a welfare system in providing care at all sorts of levels, whether it be, kind of childcare to poor mothers, whether it be unemployment insurance, whether it be food in contexts where people might be food insecure. So that would be an example of a broad-based social policy and social infrastructure, which is not about a discrete targeted intervention. What would be another example of a category which is even broader is, and I think which, COVID really is hopefully going to force countries to think about, is the ecological question. About nature-human interactions in cities, but far beyond cities. That lends itself to some technical interventions, but it demands a lot more in terms of broader economic policies, energy policies, behavioral changes, a kind of complex composite and assemblage that is not about one thing that you can leverage.
There's an additional question that goes in the same direction, which is, would you say in general that what we see as a response to pandemics are mostly technical interventions to avoid any kind of discussion around the welfare state?
I think that was definitely true in certain parts of the world, and the huge enthusiasm around vaccine development, right? So for example, in the United States, the kind of single-minded focus of successive administrations at Trump and now even the Biden administration on treating vaccines and vaccine rollouts as the silver bullet definitely takes away attention from the recent several decades of underinvestments in public health and welfare systems, which are broken, right? Community level interventions, which are broken in this country. So you kind of have to put all your eggs in the basket of the magic bullet. But I think what is very interesting to learn from is countries which didn't put their eggs in the technical intervention basket, which actually wielded broad-based social, institutional, infrastructural capacity. So Vietnam is a great example. Japan is a great example. They were not using digital apps or vaccines or drugs or any kind of one single measure to deal with the pandemic. And they did deal with the pandemic. They have dealt with the pandemic very successfully in comparison to most US, European countries. And I think one needs to study that more closely. And one of the things that I find very interesting is how the field of global health, both in this domain of global health security, but also in other domains, the field of global health as a field of expertise has excluded the histories of countries from East Asia. So what it ends up paying attention to are countries, especially in sub-Saharan Africa and secondarily India, and what it kind of draws its expertise and paradigm from is the US and Europe. And somehow the East Asian and Southeast Asian examples have just not been studied and integrated. And I think that leads to certain systematic ignorances in the global health field expertise. That's, very prominent in the context of COVID.
Have we got any more questions, please, either on Facebook, and I will report them, or in the chat?
Can I say something? Thank you very, very much for this very, very interesting presentation. Exactly on your last point, if we have these very successful or partially successful cases of East or Southeast Asia, can we compare them with India or not? I mean, what is the situation between these successful examples and India? And the second question is, if we get a bit deeper into India and try to avoid this nationwide view, and we get a bit deeper, what are we going to find? Are we going to find differences in terms of city versus landscape, class difference? I'm always talking about the situation around the pandemic. Yeah, so if we, I think you understood what I'm trying to say. If we get a bit deeper, because India, as far as I understand, it has this regional governing tradition, at least. Are we going to find similarities, differences? What is the situation?
Yeah. No, thank you very much, Georgios. It's an important comparison to make, especially because it highlights how India has invested and not invested in its social infrastructure, and especially around things like health and education, right? So, I mean, the story really at an aggregate level is one of contrast, where India has over the last several decades done an extremely poor job of investing in public health and public education, primary level health systems and primary education systems, right? And in terms of aggregate numbers, that is vividly shown. And so this contrast really is with countries in East Asia, Southeast Asia, but even with some of its neighbors like Bangladesh, which have done a much better job than India has done. And there are all sorts of kind of interesting historical reasons of why India has taken this trajectory, which in so many different ways in the health system, in the health sector, actually mimics the United States rather than any East Asian counterpart. But I think the point that you make is an important point. Like the second question you make is actually the level at which maybe it is more instructive to take that comparison, which is not to just leave it at the level of aggregate national comparisons, but actually break it down at least to state-based levels, right? Because there are historically different parties and governments in different states. And I think the example that gets trotted out most commonly in the political economy of development is the comparison with Kerala, right? And even in the context of COVID, when you stop talking about India versus, let's say, Thailand, but you start talking about Kerala versus Thailand, you come up with rather interesting distinctions, because that is one state which does have a history of socialized welfare systems, whether it be in terms of education, whether it be in terms of primary and community level health systems, whether it be in terms of provision of food and public distribution of grains. And you do see, therefore, a remarkable difference in things like death rates and hospitalization rates, even though the numbers in Kerala at some point went up very high because of returning migrants from different parts of the world coming in. So I think it is helpful to disaggregate large countries like India. The state would be a kind of obvious level at which the analysis can take place. But but I'm sure it could be instructively taken, done at the level of the city too. There are certain axiomatic things that I think in global health we trot out, right? One is that any sort of inequality that already exists that fault line is going to be exacerbated in the context of a public health emergency. So in the case of COVID, I think what is most commonly said is just like the virus in a human body finds the pre-existing morbidities, the pandemic in a society finds the pre-existing weaknesses. So class is definitely one of the cleavages around which you see, where you can, along which you can understand the differential impact. The rural-urban is another obvious one.
I see one more thing. You talked about the index being a performative one, and then you explain it as it produces the phenomenon it's supposed to measure. Could you please develop?
Yeah, so the performative point was in the context of the emphasis that the index plays on reporting functions and communication functions demanded of governments by global coordinating agencies. So about a third of the indicators and sub-indicators in this index are actually about questions like, does the government report cases of zoonotic transmission on an annual basis to the US CDC and the WHO? Things like, is there a public reporting on an annual basis of morbidity and mortality due to X, Y, and Z new infections? Is there a communication system in place for informing neighbors about the emergence of certain kinds of diseases? So there is indicator after indicator after indicator in this index, which is concerned with governments reporting to a global and international machinery. I'm interested in this. I mean, when I was going through this, these indicators, this stood out so prominently. It really caught my attention. And so what are they trying to do here? Why are they emphasizing? I mean, a government clearly has to spend more time on these reporting functions than actually addressing the problem of health. If this indicator, if this index was taken at face value, and clearly there is a kind of incentive in this index for governments to do exactly that, to invest in these kind of reporting functions. And it really, I think there are many things going on with this emphasis on reporting and communication. But one of the things, at least, that's going on is that the way accountability of governments is defined within this paradigm is in terms of a certain notion of transparency. And what is this definition of transparency? What is this notion of transparency? This notion of transparency is defined in terms of the ability of the government to report adequately to its neighbors and to the world writ large. So accountability is not about, do you achieve a certain public health outcome? Accountability is not about, is your public health system, does it have a certain capacity? Accountability is defined in terms of this performative reporting. This is very resonant with many other developmental regimes, but also in global health. This is a kind of common refrain where donors are constantly asking NGOs and governments to audit and report, audit and report. And NGOs and governments routinely say that they spend more time and more resources on their audit and reporting functions than on the actual project that they're supposed to work on. This is seen again in the global health security paradigm. So it's very much in keeping with a larger trend. And this is what I call a kind of performative visibility being at the core of an understanding of accountability. There was a second part to the question that I...
No, I think that was it.
That was it.
That was it, yes. Are there any other questions?
No, I don't see anything, but I would like to say something from the chat, from a friend who has left the meeting, is Eleni Sikeridi, but she is thanking you, Manjari, for a very interesting talk, and say goodbye.
Have we got anything else? Then yeah, see.
No, there's nothing, no comment from the Facebook
Okay.
list.
Some closing words?
From the live streaming.
Any closing words from Kostis or Manjari?
Well, thank you a lot. I mean, it was a very interesting talk. You had a lot of questions. I imagine that you are a bit tired. So let's hope that we'll join you in the future in some other events. And if no one else has anything to add or to say, we could end the seminar here.
Manjari, join us in 2 weeks for David Harvey in English again, right? Because next week is going to be in Greek, so it won't be very helpful for you.
I will do so. And thank you very much. This has been very interesting. And if any of you are ever in New York, sometime in the future, it would be lovely to see you in person.
Okay, we save that.
So thank you very, very much.
Thank you.
Very much.
Bye-bye.
Bye. Bye.
Ευχαριστούμε όλους και όλους.
Γεια χαρά. Επόμενο σεμινάριο, επόμενη Τετάρτη, είναι ο οργανωτής εδώ της κουβέντας, ο κύριος Άρης Καλαντίδης. Σας ευχαριστούμε. Γεια σας.
Καληνύχτα, γεια σας.